Hi everyone, I completed my level 1 pediatric fieldwork at Hope of Life in Guatemala, so I will just be taking the next few minutes or so to talk about my experience. So any initial ideas or expectations I had about the site or population. I honestly really had no idea what to expect going into this experience. Dr. Lavery had visited this site about 2 months prior to us going, and she did share her experience. I did know that I would expect to see children coming from backgrounds with trauma or malnourishment, as well as just some limited resources available. But I tried to reflect on my own biases before going into this experience and keep an open mind. And then how are these initial thoughts or expectations confirmed or refuted? So going into my first day of work, I was at Kelly's house, and this is a house for children with physical disabilities. And I quickly saw that there was a lack of staffing and lack of resources available. The lack of staffing was very evident when I went into the first room of the morning. There was one caregiver, and she was bathing all of the children for the day, and I believe there were about 8 children in this room, and she was doing this completely on her own. So I definitely saw that right off the bat, which definitely kind of confirmed one of my ideas prior to this, that there would be some limited resources in some way. I didn't really realize the great deficit that the staffing would have on this population. But just throughout the week, I was able to see how that lack of staffing impacted the children and their ability to have time to play and engage in those occupations that children should be engaging in. And then next, what content from your OT coursework did you get to see in action in each setting? So I'll stick with Kelly's house first. When I first got there in the morning after the caregiver was able to bathe the children, we worked on some dressing. So we talk about dressing a lot in our courses, but I have never really completed it on my own. So I was tasked with dressing. She was a 12-year-old girl with cerebral palsy, and she was also deaf. So she was nonverbal, and I already went into it knowing that there would be a language barrier, and then on top of this, it made it extra hard because she did not know sign language. No one had taught her sign language, so I didn't really know what she was capable of in terms of her independence. So that was interesting to see, and as I was dressing her, like as we progressed throughout getting her dressed, I could see that she could clearly do most things on her own. So that was really encouraging to see, and I let her kind of take the lead, which was great. And then more from Kelly's house, we worked on some feeding. So we sat with about 4 kids for feeding, and all of these kids had cerebral palsy. I witnessed Professor Williams trying to feed one little boy, and he had poor oral motor skills and just like ability to suck, and the food that they were giving them was very liquidy yogurt. It wasn't even like the solid yogurt that we normally eat. It was very liquidy. So watching him try to eat from a spoon, he couldn't control the liquid that was going into his mouth, and it would just fall. And that was really interesting and saddening to see, because Professor Williams and I talked briefly about it at the table, that it would be so much easier if he had something thicker or just of more substance to work with due to his poor oral motor skills. And then lastly, from Kelly's house, I worked with a 2-year-old with hydrocephalus, and we worked on just some developmental milestones. We worked with the PT, who was also there, and under Professor Williams as well, and we worked on rolling over. So we worked on first massaging his pectoral region to help those muscles anticipate the process of rolling over, and that was really interesting to see. And it was interesting, we would assist his arm over by pulling it over his body, and then he had trouble clearing his left arm from under him to get it out of the way to complete the rolling over position. And that was interesting to see as well. So moving on, how did I demonstrate my therapeutic use of self? So this was really important in this setting. I relied heavily on my therapeutic use of self by staying patient and flexible and responsive to each child's cues, especially when the language barriers were present. So I just tried to use my own reasoning and looking at these nonverbal cues from all the children in all the different settings. And that was really helpful. And then one more experience that I forgot to mention was at the St. Luke's Hospital. So there were, I believe, 7 or 8 infants in the room. And we worked with one infant on prepping for standing. So when we would pick this infant up from seated position, his legs would become in a flexed position and he would not reach the extended position to have them touch the ground. So working under Liz, our supervising OT from UCSD, she suggested shifting of positioning. So we were able to put the baby on our thigh. Both legs would be, or like a leg would be on each side on the mat. So he would work on that weight bearing to get into preparation for standing, and that he seemed to tolerate that for extended periods of time, which was very encouraging. And then we also completed the Day C assessment there, which was really cool because we had talked about that in class prior. Okay, now moving on, how did your emotional intelligence improve over the course of the experience? My emotional intelligence definitely grew through this experience. I learned to read nonverbal communication more accurately due to the language barrier and adapt my interactions based on each child's comfort level and the caregiver's need. So how do you think this fieldwork experience has impacted your professional identity? So this experience has been so valuable, both for my personal and professional life. It has showed me the real world impact of occupations and also just reinforcing how important it is to have a global health perspective and look at community-based practice in an area that has limited resources and limited staffing. And then what skills did you carry over from your first level 1 fieldwork experience in mental health? So for my level 1 fieldwork, I was at St. Madeleine Sophie Center working with adults with developmental disabilities. So different populations for sure, but I definitely used some of the same skills that I used there as I did here. I tried my best to build rapport with the clients, so in this case the children as well as the caregivers. I wanted to have a calm and just warm presence for the kids. I know most of them come from traumatic backgrounds, so kind of bringing in that piece of trauma-informed care was really important. So, and just going off of that, adapting some of the activities to meet the needs of the children, because we worked in big groups of children, so kind of having to pick up on all of that was really important. And I did that at St. Mad's as well, seeing a big group of individuals with varying level of function, and kind of just being able to maintain my composure throughout is really important. And then how will you use these experiences gained from this pediatric rotation in your next level 1 rotation, working with adults? So moving into my next level 1 rotation, I want to take my ability to kind of think creatively with limited resources, and the confidence to kind of modify these tasks on the spot. I think I've also gained a deeper understanding into culturally competent care. This experience has been invaluable in that sense. I really truly saw like a different part of practice in terms of occupational therapy that I know will help me excel in my next level 1 fieldwork rotation. And again, just maintaining the client-centered care across different populations. Thank you.